this is, um, I'm sure everyone is very tired of hearing about COVID already, but this presentation is a little bit different. Um, um, this isn't exactly about the COVID virus itself, but it's more so about the restrictions that were put in place for COVID. And what those restrictions had on outcomes and cardiovascular health. And like Dr. Ligari just said, this is data from Nova Scotia, but I think it is relatable to New Brunswick, and I'll kind of talk about that along the way. All right, so I just wanted to quickly acknowledge a few people who've helped with the study. Dr. Parkash led the study and she was an excellent mentor, as was Dr. Hirsch. Eileen Davis and Karen Giddens, they managed our sources and our data really well and they were really excellent to work with. And finally, Navjat was our statistician, and I don't know if we could have done this without Navjat. All right, so March 2020, the COVID-19 pandemic happened and changed everything for all of us. Flights stopped, isolation became our new normal, and the delivery of healthcare really changed. We were very aware of the large numbers of very sick patients around the world who were pushing their healthcare systems to the brink of collapse. And I'm sure you guys have seen different variations of these things, but the match that shows how social distancing works, different closures, new limitations, and really just widespread media coverage about how bad coronavirus was and how different places around the world were really struggling because of it. So the primary goal around the world became to stop the spread of COVID. Hospitals really reduced the delivery of non-COVID services, and that was done with good intentions. People were anticipating the need to liberate resources for patients who had COVID, and also, we wanted to stop or curtail the spread of disease among patients and healthcare workers as well. So on March 17th, 2020, and I think around the same time for New Brunswick, the Nova Scotia Public Health came out with some pretty aggressive measures and restrictions. And ultimately they worked. We had minimal community spread of COVID-19 and no major surges in hospitalizations. And around, I guess, for the entirety of this study period, so until December 31st, 2020, in Nova Scotia, we had very low numbers of COVID-19. They range from 0 to 8 patients per day during the study period. But then we started to see a different side of things. So we had a lot of empty beds. We weren't operating, procedures weren't taking place, but health was still happening. So patients were out there having things like strokes, and they had cancer, and they were having heart attacks, and we weren't really seeing them. And then in the summer months, we started to see sicker patients than usual, more patients with mechanical complications of MIs, more patients that needed mechanical support. So this kind of led us to this study. And we asked the question, what effect did healthcare restrictions and the public response to them have on outcomes in non-COVID cardiovascular disease? And I will point out that we thought this was a good study to do in Nova Scotia because of the very low burden of COVID that we had. So we did a quasi-experimental design study, and we used an interrupted time series analysis. The time series analysis was used to compare trends over time, comparing 2 study periods. For us, that was the pre-COVID and the in-COVID periods, which I'll talk about in a second. And we compared outcomes in patients who were 18 years and older with existing or new onset cardiac disease. And our outcomes looked at different rates of emergency department visits, hospitalizations for cardiovascular disease, out of hospital cardiac arrests, acute coronary syndromes, and waitlist mortality. So the 2 time periods that we chose, the in COVID, I think is pretty self-explanatory. So that was from the date of the onset of restrictions, so March 17th, 2020, until the end of that year, December 31st, 2020. And then for the pre-COVID period, we chose March 1st, 2017 until March 16th, 2020. So we had 3 years of data there. And the reason that we did that was that we wanted to kind of ensure that the trends that we were comparing the in-COVID period to were properly identified for comparison. So this is the setting, and I think Nova Scotia and New Brunswick are quite similar in how the healthcare systems are set up. So both provinces have a single emergency or ambulance system. It's public healthcare. There's no private system that's paralleled. So that makes, getting data capture and that kind of thing a lot easier. And I think the organization is a little bit different, but essentially we have networks of hospitals that are regionalized into secondary care. And then those kind of all feed into a single tertiary or quaternary referral center. For Nova Scotia, that's the QE2 Health Sciences in Halifax, and St. John Regional Hospital is the largest tertiary care center in New Brunswick. We used a lot of different sources to capture our data. So our out-of-hospital cardiac arrest numbers came from emergency health services. We used NACRS and HDNS to get more information on cardiovascular hospitalizations. And some things came directly from their associated database. So we used the STEMI database, the TAVI database, and Approach for the PCI and cardiac catheterization. And then unfortunately, the surgical database was the only one that wasn't up to date. So we had to comb back through that and do a retrospective chart review. And I was the lucky one who had to do that. This is just to give you an indication of the kind of numbers that we are working with this study. So 51,000 patients for emergency department visits, for ambulatory patients, 14,000, hospitalizations, 20,000, and then out of hospital cardiac arrest, 5,000. So we did have big numbers in the study, and those are broken down into pre-COVID and in COVID periods as well. In terms of baseline demographics, there was no real difference comparing the pre-COVID and the in-COVID groups. All right, so we're getting kind of to the meat of things now. So you're looking at the emergency department visits, and along the x-axis there, that's from March 2017, and it's actually even longer than the study period, up till March 2021. The number of department visits are on the y, and each of these different colored lines is representing a diagnosis or a chief complaint that patients came into the emergency department with. And I will point out this vertical red line that you see here. You're going to see this a few times in this presentation, but that line always shows where the restrictions happen. So that's March 17th, 2020, and most of the figures. And just looking at the different color lines, so the top one here, the navy blue one, that's showing all cardiovascular and neuro visits, and the darker green in the middle is showing chest pain NYD. But we had a dramatic decrease at that point when the restrictions came into play. And we decreased our emergency department visits by 20.8%. And that was significant with a p-value of 0.001. And following the restrictions, it took about 8 months to get back to pre-pandemic numbers, but each month we kind of saw an increase by about 2.8%. And this is our out-of-hospital cardiac arrests. I know this is a pretty busy figure, but I'll break it down for you. So on the x-axis here, that's showing the month from January down to December, and you're looking at the number of cardiac arrests on the y. Each of the different colored lines, the horizontal that you're seeing, is a different year. So 2017, 2018, 2019, and then the darker red is 2020. Again, that vertical red line that you're seeing is the onset of restrictions, so March 17, 2020. So the usual pattern for out-of-hospital cardiac arrests for the preceding 3 years was that there was a maximum number of arrests in the winter with a mean of about 126.9 cases. And this would gradually decline and have the fewest number of cases in the summer with a mean of about 106.8. In summer 2020, the opposite happened. So there was actually an increase in the number of out-of-hospital cardiac arrests with a mean of about 137.7. And this vertical yellow line that you're seeing here, that's the change point line. So that's the point at which the trend changed for the year 2020. And that was identified in May 2020. This graph is showing the mortality rates for patients I guess, in non-tertiary care centers. So these are patients who were not transferred. And I'm not quite sure what the restrictions were for New Brunswick, but we were very, very limited in who we could transfer to the QE2 Health Sciences. And we actually decreased our admissions by 48% in that first month of the restrictions coming on. So this is just to show the mortality of patients who were at their home hospitals. So on the x-axis, there's combined total patients who came in with STEMI and STEMI unstable angina and heart failure. And the 30-day mortality rate is on the Y. So in everything except for NSTEMI, there was a trend towards increased mortality, and it was significant in patients who had congestive heart failure. So patients who had congestive heart failure and were admitted to their home hospital saw an increase of mortality by 74.3%, and that was significant with a p-value of 0.006. This is to show the number of CATs and PCIs that we did during that time period. Again, when that red line is showing you the March 17, 2020, and you can see there's a pretty significant drop there. So we decreased the number of cardiac CATs that we did by 44% in the first month of the restrictions coming into place. And it did take us a while to get back up to our normal numbers as well. And I think this filters quite nicely into the next slide here. So these are people who were on wait lists for procedures, and it's showing the mortality rates for those patients who were waiting for different procedures or surgeries to be done. Along the x-axis here, you have different cardiac procedures as well as cardiac surgeries there. Mortality rate is on the Y. The blue is showing you the pre-COVID numbers for mortality, and the red is showing the in-COVID numbers. And if you look on the far left here, for all cardiac procedures, there was a significant increase in the mortality, and that was with a p-value of 0.001. And it looks like that was really driven by patients who were waiting for cardiac catheterization. So they also had an increase in mortality that was significant. And I just showed you that, we decreased our number of CATs quite significantly. So it is an interesting finding. And patients who were waiting for TAVI or were waiting for CABG did show trends towards increasing mortality, but these weren't significant. All right, so some take-home messages. This was a really big project. I haven't actually shown all of the data that we captured. I just kind of showed the things I thought would be, I guess, comparable for New Brunswick if you guys had similar restrictions to us. But, that decrease in emergency department visits, that's a complex thing, and it's hard for us to say why people weren't going to the emergency department. But a lot of patients that we talked to said things like, we were told not to come. They said to stay home if you're feeling unwell, or they were just afraid to catch COVID. So a lot of patients weren't presenting when they were experiencing chest pain and things like that. There was an increase in our out-of-hospital cardiac arrests, an increase in mortality in patients who had congestive heart failure and weren't able to be transferred to a tertiary care center. And there was increased mortality as well in patients who were awaiting cardiac procedures, and especially in patients who were waiting for coronary catheterization. So we concluded that the indirect effects of COVID and the healthcare restrictions that were put in place because of it resulted in increased morbidity and mortality in patients with cardiovascular disease. And in terms of patients with cardiovascular disease, we believe that these findings in the future, if there is another pandemic or another big wave of this pandemic, could be used to help inform policy around healthcare delivery, and especially in communicating with the public about, the importance of what to do if you feel sick and what red flag symptoms would be there for cardiovascular disease that might warrant a trip to the emergency department. And that's kind of everyone that helped out with the project. And I'll take any questions now.
Thank you, Alison. This was great. I'll ask you to unshare the screen, then we'll see you a little bit better. And
yeah, sure.
A couple of comments. Anyways, a very interesting study in many ways, and I think there'll be several years, I think, of us sort of looking at data around what's happened and how we potentially could do things differently. And I think what's striking is the image you showed of the empty beds. I certainly remember acutely our approach initially in the pandemic was really, we were very good at closing everything. And what I'm surprised is how it took such a long time to recover your capacity, because I got the sense that we recovered capacity pretty quickly and we sort of never put it back down. And how do you think it's the way they redeploy nursing, what are the sort of things that that sort of impacted that part of the question?
So we've had several shutdowns similar to the first one. First of all, we did have that major shutdown when things first started. And then we went into summer, and we actually did do a normal summer slowdown. So we lost a room, and closed beds and things like that. And then we did have another, when there was another wave happening in the fall, we had another shutdown, the same thing, where we went down by 50%. And we've done that basically for every time. So even though we haven't had huge numbers in the hospital in terms of COVID patients and sick patients, we were still, liberating our resources and trying to make room in case something happened. But for the first part of the pandemic, for the first year, we really didn't see huge numbers that were in the hospital and, taking the ventilators and the ICU beds and things like that.
I wonder if, from a policy point of view, I mean, I'm obviously selfish in thinking cardiovascular outcome are more important than other illnesses, but
we all feel like that.
Many provinces approach this issue, not all provinces, that cardiovascular restrictions would be the last to be impacted by restrictions. Some provinces actually favored making sure that cardiovascular care would be maintained. And I don't know if you would comment on that.
Yeah, I mean, we struggled with that as well, but we really haven't done that. So, the reason that I'm here right now is because we went down to 50% again, and we're 2 years out, and there weren't very many hospitalizations for ICU or in ICU or on the wards for COVID patients. But I think I guess we're just kind of using all the surgical specialties. I mean, we could debate that a lot, but I don't know why we didn't push harder, but it doesn't seem like we did, unfortunately.
Yeah, very interesting. One last question from my point of view is did you look at all at, now we've looked at cardiovascular specific, but I still feel that we're missing a piece in the sort of excess mortality. And this is one of those, you look at yearly trends of mortality in a province, it's not perfect, but maybe that we are still, even in the data that you're looking at, maybe we are missing a bunch of cardiovascular morbidity that we just didn't pick up because people died at home and died without telling anybody, never presented, and that kind of stuff.
Yeah, I mean, that we were interested in that in that finding for sure, because we think that's a big part here, that people just didn't present, they didn't come into the emergency department and so forth. But we didn't capture it on this, unfortunately. And I'm not even quite sure how we would go about it. It's kind of hard to do. I guess we would just have to look at all mortality and see if it was due to cardio causes or exactly what happened. But it's an interesting thought. I mean, yeah, I should talk to Dr. Parkash about that because it is interesting. Yeah.
Yeah. So there's a comment from Colin. I see his hand put up there. Go ahead, Colin.
Yeah, I'm just wondering if you plan to share this with public health, because, I think all of us feel that the restrictions far exceeded what was necessary and went on far too long for necessary than was necessary. And, I think your outcomes with sudden cardiac death as outpatient, that's probably the big, one of the more obvious things. People were just scared them into coming to hospital, and they sat at home with symptoms for a long time. So I think, this needs to be shared, if at all possible, with public health, because for 2 years, the overwhelming priority was just COVID, and really did not see the big picture at all. And we could go on about all the restrictions, how they made no sense. And Dr. Legary we were all beating our head against the wall for a long time, getting nowhere.
Yeah.
So I really feel that it's an important study, and in sharing it with people makes a big difference. And if only to learn for it and to direct us going forward, and to, critically appraise the decisions that we actually make and still make currently, because we're still not in a normal situation here at the hospital. And anyway.
Yeah. We presented our results to NSHA, so the president and the vice president of NSHA, but we never really did get a public health meeting. We did approach them, but it never really happened. So I don't know. We were hoping that.
Just share it with media, I think it's
we talked about that as well.
The discussion needs to happen, and it's not to to point fingers. It's just to try to learn, and if people don't want to hear it, then they'll hear some other way indirectly. So it's just an important discussion that needs to happen. And if people don't want to hear it from the people who want to help, then they can hear it from a newspaper.
Right. That's fair. Yeah. Thanks.
Yeah, I agree. I think from a public policy, and I think the public is going to be your biggest voice. So if you can convince the public will influence government, will influence policy. I'd actually even push further that, government, not to lay blame again, we focused so much on COVID that for the last 2 years, every single effort or policy or things you might have wanted to improve or change in the healthcare system has been put on the back burner. There's really been no discussion on how to improve, how to change, how to address weight, whatever it might be. It was always, we're busy with COVID. We're busy. Yeah, everybody's busy with COVID. We're all dealing with COVID. But at the same time, we've really, I think, let down patients.
Yeah, agreed.
So anybody else, any questions you'd like to bring forward in our rant on government? It wasn't meant open. Is there anybody from government on this call?
Yeah, exactly.
They should have been on this. Anyways, Alison, thank you very much for your time and presenting this to us. That was very good work.
Yeah, thank you very much.
Thank you. Have a good day. Thank you.